So I'm going to talk to you about variability and why that's one of the hidden problems in cardiology. You often see it in conferences, actually, that you go to a panel and there's 8 opinions and you think, which one shall I take home with me? So, as I said, in partnership with GIS, not the kind of picture you normally see in a talk. This is me about to take some video of my cycling in London. And what I'm doing here is using London traffic as an analogy for variability. I know where I want to go, but it's the side roads, the weather, the traffic, the pedestrians that are going to stop me getting there, all the hidden variability. So this is just, I got this camera the day before, so I just filmed my next ride in London and I'm on the way to the hospital. You'll see that actually I've managed to organise, not sure what the lady's doing. What are you doing, lady? A police escort to take me there, and you'll see what happened along the way. So I always do a quick shot of my nostrils before I start. There's no better way to start a ride. Glasses on. This is me in central London with my police escort. What's happening there? Gentleman deciding to step out in front of me. So go on literally just around the corner and decide to take a turn into this next part of London. Lots of craziness going on. Police nearly killed me here. And then the driver decides the road is not enough. I'm just going to take the pavement here because, well, why not? And this kind of craziness, this variability is what often stops us, derails us from our goals. So let's go back to the cath lab. This is a gentleman called Josh. At the time that he presented, he was 40. He was on a ski holiday in France. And here he is enjoying himself in ski holiday when suddenly he experienced some chest discomfort and then presented to a hospital in France where he was told, if you don't speak French, that he's having a heart attack. And they found he had this calcified diffuse LED, but unfortunately also 3-vessel disease. And they felt that his goal was to get back skiing as quickly as possible. And therefore, the answer to that problem was a stent, of course. It's the answer to every problem. We're going to give you a stent and you'll be back skiing. And that was the start of his journey in his 40s. And he had 2 stents into his mid-LED, no imaging, and was sent back to the UK and told that he had some disease in other vessels. And when he went back to the UK, he had some further procedures. Firstly, a stent to the distal LED. Then they found the first stent was under-expanded, so they expanded it. And then that didn't seem to work, so they expanded it again. And here we join him 18 months later, and he's already had 4 coronary interventions, all slightly different, none of which have actually looked at the cause of his problem, and there's not a single suggestion of any imaging at this point. And he comes back in with more chest pain and feeling pretty dispirited. At that point, he'd sort of lost faith in his local hospital, and he got sent to another hospital, and they did laser, and that sounds very exciting. Every time you mention laser, it's very engaging. So he had laser to his distal LED, and he thought, great, problem solved. That's what I needed the first time, laser to my LED. So we'll leave Josh. I'll just let Josh's story hang there. Probably there's a happy ending, maybe there's not. Let's see. So what I am talking to you about and what we're going to focus on in the next couple of talks is variability and how variability in care harms patients. And when we look for it, we see it everywhere. So it's worth asking ourselves, what's causing this? And you can consider this in some way the perfect storm of modern life. Just some insight into the kind of things that cause it. This swirl, this storm of information. Here we are back in London, surrounded by social media, by traffic, by weather, by noise, by lots of distractions. We are trying to communicate with patients in the context of all this and give them clear, unambiguous information, whilst at the same time delivering the care that they deserve. And this is what we are calling now the perfect storm. If we think back to Grunsig all those years ago, getting up for 50 years ago, when we invented angioplasty, the job was just to open up an artery that was blocked in the context of a STEMI. And it was a very limited goal, but if we find out where we are now, it's very, very different. And this perfect storm is caused by lots of changes in angioplasty over the years. Primarily our environment. Cath labs have changed beyond recognition. We're surrounded by all the things that distract us. We're often sleep deprived. Perhaps I am a little bit this morning. The stress that drives the demands on us. And we're surrounded by all this distraction. Somebody saying, we've got 10 patients waiting, why didn't you hurry up? The patient's uncomfortable on the table, they're moving their hand, there's demands from outside. And all this is influencing how we make decisions, how we act. And you can see that hidden in data. It's often not overt, but here's an example of a study which compared complete revascularization with staged complete revascularization. So you either did it all at once, or you did it in stages. And obviously there should be no difference in terms of imaging, but actually you found it was double the amount of imaging if you did it in stages. In other words, if you weren't fatigued, you had time to take your time, but if you felt rushed, you would do a lot less physiology and a lot less imaging. And I don't think the next data is going to come as any surprise to us. What do we think, for example, happens in the middle of the night? Do you think we do more imaging and more physiology? Well, obviously we don't. It falls off a cliff. We just want to get back to bed. We want to make a down and dirty decision. The sad thing is the needs of the patient are just the same at night as they are during the day, but the environment is driving this change in our behavior. And patients are part of that environment. They're much more complex than they used to be. They have a lot of associated problems, renal failure, frailty, all sorts of issues which influence decision making. Calcium, of course, on a very technical level. And just one example is this nebulous concept of surgical turndowns, which is, you go to conferences, it's not really discussed, but in real practice, 1 in 3 patients who might be better off with surgery or decline surgery. And that means we're doing more left mains, we're doing more hemodynamic support, there's complex programs springing up everywhere. Yet we know these patients are a strong risk factor for failure in the therapy we apply to them. And then technology is the answer, or is it the answer? It's everywhere, but how do we assimilate it into our practice? How do we get the good bits without being overwhelmed by the minutiae of it? And then resources are also a very real issue. We think of resources like money, but often it's our time and how we apply that time to make decisions in the right way, and how we regulate the decision making and share it out amongst the team. I talked on this a little bit yesterday, but part of this is the information overload that we're all confronted with. How do we take what's relevant from the information and apply it to the process that's in hand? So if you're asking yourself the question, how should we be best guided by clinical care? What should be part of that decision making? Well, the angiogram's a given, but there are all these other technologies that are finding their place and need to be part of the workflow. Physiology should guide us where to go. Intravascular imaging should guide us how we get there. And then we've still got to integrate the data, and the data is never ending. It's an evolving landscape, never mind the guidelines, which appear usually 5 or 6 years after the data. So it's no wonder that this perfect storm affects us in many ways, and I want to illustrate that by just asking you as the audience a question. So I'm going to give you the clinical information that we're confronted with in 80% of time in cath labs around the world. 70-year-old man, he's got angina, normal LV function, renal function doesn't look terrible, and this is his angiogram. I'm not going to describe it for you because you're all experts in the audience, but I am going to ask you a question about how you would treat this gentleman. Okay, you've got 4 options. First option is left main LED. You'll get a poll up in a second. Second option is a more complicated 2-stent approach. involving the ramus, provisional to the circ. Third option is send him for surgery. And fourth option is OMT. Okay, so if we can go to the polls. Here's the poll, so if you just scan that and have a vote for me, please. Do I go on again, Michael, here, or what's this deal? Does it just pop up, the answer? Okay, so here's what you think the answer is in real time. So there's quite a lot of people have gone for 1 stent. There's a few people gone for 2 stents. There's some people got into the wrong conference here who thinks that surgery is a viable option for anything. And thank goodness nobody's gone for medical management. There's no role for tablets for sure. But what you can see is that there's significant variability in the audience. There's not really a concordant view that we're landing on here. And you can see that'll continue to show that. And that's complexity is the new normal. So this is the standard. That's actually a relatively simple case. But the more variables there are in the case, the more likely are people to get lots of different treatments. And we have to have some way to align to the goals of patients. In our opinion, decision making is going to be key to that. But it has to be aligned to the goals of the patient. We have to be able to communicate to patients in a way that's meaningful to them, that this is what we can give you, this is a value offering, and this is the risk benefit in terms of deliverability. So you'd be wondering what happened to Josh. So that's really, when we left him, things were pretty good. Back in 2018, he was pain-free, he had the magic laser, all his problems were solved. But unfortunately, he represented some years later with more chest pain. And at this time, he had cutting balloon, another stent, so he's got quite a few stents in his LED at this stage, all in the same place, and lithotripsy in that order. Slightly unusual approach. Again, no imaging. And he presented shortly afterwards with an end-STEMI. And that led to yet another intervention where he had POBA, laser, and DCB. So at this stage, we're up to 6 interventions, and he's still got chest pain. 7 interventions later, he's still got chest pain. And actually, he ends getting up to refer to another centre, which is when I first encountered poor Josh, having rotation atherectomy to his stents as part of a live case for TCT. And we can kind of reflect on his pathway and think, how could we have made that better? And obviously there are lots of variables at place here, but maybe if we'd aligned to his goals at the start and felt, actually, we know you're on a revast journey here, but how can we minimize the number of stops you have in it? How can we optimize your first destination and make it hopefully your final destination? So poor Josh is left with not necessarily a huge amount of angina, but a lot of anxiety about what's next. He's lost confidence with healthcare because we haven't been able to give him a consistent solution to his problems, and probably because we didn't listen to him in the first place. But there is another version of Josh's story where we do think, actually, what matters to this relatively young gentleman? How can I make this intervention durable? How can I plan it in a way that I'm going to minimize his interaction with healthcare in the future and let him get back to skiing and so on? And I guess it's a little bit like my journey. How do I make my journey as a cyclist safer in London? I can plan the route, so I use Cycle Pass. I can look at the weather and avoid rain. I can make sure the police escort doesn't try and kill me. All these things can be done proactively to minimize the variability. And we talked about information overload yesterday and how it's very, very difficult to take all these variables into account when we're in the middle of doing things. We have to take a step back Taking a step back is what we call proactive PCI, and that's what we're going to explore over the next 2 talks. And I think Josh is not on his own out there. So if you're embarking on your journey, God forbid you're going to cycle through London, but if you're crazy enough to do that, take your time and plan it. And remember that Josh is waiting for you when you go back home. And whether it's Josh or some other lady or man, they deserve the best of our care, and that involves planning. So thank you for your attention, and this is just the introduction of the next couple of talks, which explore these concepts further.